Okay. Sige. For this day, we will be discussing drugs for diabetes ha. So this is chapter 28 and this is included in the laboratory exam. Now before we move on to the drugs and the pathophysiology of diabetes, let us talk about glucose first. So I believe you all know that when you say glucose, we call that physiological sugar. Okay? That is our number one source of energy in the body. So, we can obtain that one from the food na kinakain natin. Okay? So, if we, anong tawag dyan? Intake foods that are rich in carbohydrates, syempre, i-break down yun siya sa body and it will be converted into energy. So, most of the time, we consume polysaccharides. Okay? So, I think, nag-review na kayo ng biochem and orchem, so you know this very well, mag-assume ko. Now, ang polysaccharides, remember, maraming glucose units yan siya. No, not just glucose units, monosaccharide units. Okay? So, for example, starch. The starch though is composed of a lot of glucose units. Okay? Monosaccharides are the building blocks of our carbohydrates. So, number one question, saan nagsa-start ang metabolism ng carbohydrates? Asa mag-start? You may raise your hand and then you may answer ha. For those who have not yet completed their recitation, even though this is a laboratory class, I'll record the recitation sa LEC. Okay? Kompleto na mo tanan og recitation, wala na mag-recite. I told you, di ba, ang excess na recitation, idagdag ko sa scores nyo sa quiz first. And then, if okay na yung sa quiz, kung daghan jud inyong recitation, I'll include that one sa exam. Okay? Amay audible? Wala pa ko'y ka-istorya din, hi?
Yes po, nga marinig po.
Okay. We don't don't ask for grades first kay lisod kaayo mag ay nakapasa? Sa midterm. I don't know with you if nakapasa na kayo ng recitation. I haven't recorded everything yet. So I don't know kung nakapasa na ba og index card. But there are students na nakapasa na og index cards. Di lang ko sure kinsa ang wala nakapasa. Wait lang, I cannot see the chat. Okay? Deadline na ng grado next week. Yeah, next week. So, baka next week pa yung grades. So, I don't know sino yung nakapasa, sino yung hindi ha. So, again, carbohydrate metabolism starts in the mouth and that is due to the salivary amylase. Other name for salivary amylase is thiolin. Okay? Now, it will be broken down into oligosaccharides. Oligosaccharides are composed of 3 to 10 monosaccharides. Now, however, aside from the salivary amylase, we also have the pancreatic amylase, and we call that amylopsin. Please take note ha, kay this will be included in our exams. Now, amylopsin, examples niyan, we have the dextrinase, ganon. It will break down the oligosaccharides into disaccharides and then most likely monosaccharides. So for starch, the last product for the metabolism via the pancreatic amylase is glucose kasi glucan naman yung ating starch, as in glucose lang talaga yung kanyang monosaccharide components. Now, if we are going to use glucose as a source of energy, we will break it down through the process of glycolysis. So as early as now, please do memorize the pathway since this is high yield in the board exam. Maraming masyadong questions about pathways sa biochem sa board exam. So in the screen, I have included there the pathway. Again, please start memorizing this pathway para alam nyo how do we break down glucose so that we will have energy. So, syempre, this will start with glucose. However, the first parts of the glycolysis will not yield ATPs. Instead, gagamit ito ng ATP. As you can see, itong mga arrow dito, ATP will become ADP. ADP is adenosine diphosphate. So this time wala pang ATPs na mafo-form, instead gagamit pa ng ATP. So yang mga cases na yan, board exam questions pa rin yan. Aling part sa glycolysis pathway ang gagamit ng ATP and anong part yung magpo-produce ng ATP. So we have glucose, it will become glucose 6-phosphate. Please take note of the enzymes involved, ha? And then it will become fructose 6-phosphate. After that, fructose 1,6-bisphosphate, and it will be divided into two using the enzyme aldolase. So that's another board exam question. Sino yung puputol? Sino yung magde-divide? That's aldolase. So the two products are the G3P or the glyceraldehyde 3-phosphate and the DHAP or the dehydroxyacetone phosphate. And then on the lower part, dito na tayo magpuproduce ng ATPs. Okay? So, itong DHAP will just be converted into G3P and the G3P now will undergo metabolism pa. So, ito na yung mga products. The 1,3-bisphosphoglycerate, 3-phosphoglycerate, 2-phosphoglycerate. Kung nakita nyo dyan, itong NAD na magiging reduced form, the NADH. The NADH actually is, ano yan siya, mag-yield din yan siya ng ATP. Okay, if I'm not mistaken, 1 NADH will be equivalent to 3 ATPs. Let me check that, ha, but equivalent yan siya into ATP also. So if the 1,3-bisphosphoglycerate is converted to 3-phosphoglycerate, it will also yield ATP. Okay? And then yung sa 2-phosphoglycerate, magiging phosphoenol pyruvate siya. And then magiging pyruvate through the enzyme pyruvate kinase. So pag maging pyruvate na siya, mag-yield din siya ng ATPs. So again, please know the flow of the pathway and then which part ang nagagamit and nag-yield ng ATP. Now, itong si pyruvate will be converted into acetyl coenzyme A, and acetyl coenzyme A will enter the Krebs cycle where we know na mas maraming ATPs yung ma-produce doon sa Krebs cycle. Okay? Now, please take note that glycolysis takes place in the cytoplasm of the cell, which means that glucose should enter the cell first before this happens, before this pathway happens. Okay? And remember that glucose is a very big molecule. Therefore, hindi ito basta-bastang pumapasok sa cell, meaning hindi ito mag-undergo ng passive diffusion lang. Now, ang mag-help ng sa glucose para mag-enter siya sa cell is yung ating hormone called insulin. Okay? So si insulin yung mag-help niyan. Without insulin, glucose cannot enter the cell. It will just stay in the blood. Okay? And that's the time magkakaproblema tayo. Okay, so let's start now with diabetes. So again, insulin is the hormone involved in the regulation of our blood glucose. Now, insulin is produced in the pancreas, specifically in the islet of Langerhans in the pancreas. Okay, it's the beta cells of the islet of Langerhans. So actually, we have different types of cells in the pancreas. We have alpha cells, which produce also hormones. So we have here proglucagon, that is the parang tawag dyan, inactive form of the glucagon. Glucagon yung active form ha. So glucagon is also a hormone. It also regulates blood glucose level. Kaya lang baliktad sila ng activity ng insulin. Si insulin, pag marami masyadong glucose in the blood, it will help in glycolysis, meaning ipapapasok niya sa cell yung glucose. Yun yung trabaho ni insulin. Si glucagon is more on the times kapag kulang ka ng glucose. So, ang gagawin niya is most of the time glycogenolysis. So, i-break down yung glycogen stored in the liver para meron kang source ng glucose. Yan yung trabaho ng glucagon. And then again, please take note, it is produced by the alpha cells of the islet of Langerhans in the pancreas. Okay? And then we also have beta cells. Please take note, beta cells, yan yung pinakamaraming cells in the pancreas, and these are responsible in the production of the insulin. Okay? Proinsulin yung inactive form naman ng insulin. Now, aside from that, these cells also produce the C-peptide and the amylin. We'll talk about amylin later if kaya pa ng time. And then the delta cells produce somatostatin. We also have G cells na nagpo-produce ng gastrin. Gastrin which is involved in the production of our gastric juice. And then the F cells produce pancreatic polypeptide. So may kanya-kanya yan silang work sa body. So ito yung mga hormones. They are all hormones produced by our pancreas. Pancreas is an endocrine gland. So it's a gland. Definitely, it will produce hormones. I believe I have already clarified that one when we discussed the difference between a hormone and a neurotransmitter. So again, hormone, it is the storage and at the same time, an anabolic hormone. Okay? So, di ba, pag sinabing, ano ba ibig sabihin ng anabolic? Wait lang ha, let me write sa screen. Anabolism plus catabolism is equal to metabolism. Okay? Yan yung equation natin. Lang. Okay. Pag sinabing anabolism, it's building block. Okay? Building block. Building up. Building up. So meaning, smaller molecules will combine to form larger molecules. And then catabolism, larger molecules will break down to form smaller molecules. Pero ipag pinagsama natin ang anabolism and catabolism, it will become, it is now the process called metabolism. Okay, and then glucagon is the hyperglycemic factor that mobilizes glycogen stores. So nasabi ko na ito kanina na if kulang ka ng sugar, glucagon will take action. It will stimulate glycogenolysis. So ang stored glycogen in the liver will be broken down, and then gagawin siyang glucose, ibabalik siya sa blood. Please take note ha, our stored carbohydrates, both human and animals, ano yan siya, glycogen. Pero pag ang question is stored carbohydrate in plants, that is the starch. Okay? And then somatostatin is a universal inhibitor of secretory cells. Pag marami ka nito, somatostatin, it will inhibit secretions from the different secretory cells that we have in the body. It's an inhibitory hormone. And then we have the islet amyloid polypeptide, or that is what we call the amylin. So si amylin, this one modulates our appetite, including the gastric emptying natin. So sa biopharm ninyo, I hope you learned that when you say gastric emptying, it will take 2 hours for us na mag-empty ng ating stomach. That is why pag kumain ka ng 7 a.m., magugutom ka na talaga at 9 a.m. Kasi ubos na ang laman ng stomach mo niyan. And the amylin has something to do with that. Okay, and at the same time, glucagon and insulin secretion. Okay, so that's again amylin. I think siya mag-next. Okay, and then gastrin, nasabi ko na kanina ito, it has something to do with the secretion of our gastric acid. Okay, and then the pancreatic peptide is a small protein that facilitates digestive process. However, kung paano niya i-facilitate ang gastric process, unknown pa yan siya. We still don't know paano. But again, it's pancreatic peptide that is produced by pancreas, small proteins produced by the pancreas. Okay, now, sabi ko kanina, if we lack insulin, glucose cannot enter the cell, and therefore there is no glycolysis and glucose will be accumulated in the blood. Therefore, meron yan siyang problem. And the problem is called diabetes mellitus. So sa diabetes mellitus, this one is characterized by increased level of blood glucose because of the absence or inadequacy or kulang, deficiency of insulin secretion in the body. So nakadepende yan siya kung meron or walang concurrent impairment of insulin action. As long as kulang or wala talaga or may impairment sa action ng insulin. Basta involve ang insulin tapos magtaas ang blood glucose, that's diabetes mellitus. Now, ano bang problema? Bakit walang insulin or kulang ng insulin? For those people na wala talagang naproproduce na insulin, it may be due to the destruction of the beta cells of the islet of Langerhans in the pancreas. Yan yung problema sa kanila. Nasisira yung kanilang pancreas, yung kanilang beta cells sa pancreas. Kaya hindi sila nagpo-produce ng insulin. However, meron namang diabetic people na nagpo-produce pa rin naman ng insulin. Kaya lang their body has abnormal insensitivity to insulin. Okay? Hindi masyadong nagre-react yung kanilang cells sa insulin. So, hindi pa rin makapasok yung glucose inside. So, ano yung reason yan? Nandyan sa arrow. Weight gain and physical inactivity that results to central obesity. Okay? Pwede silang magkaroon ng hyperinsulinemia. Marami silang masyadong insulin pero hindi talaga nagre-react yung body sa insulin due to obesity. Kasi fat cells class, yung mga fats kasi, yan yung reason. Magpo-produce yan sila ng inflammatory cytokines that will make the cells insensitive to insulin. So, yan yung problema. Sabayan pa ng genetic factors. Okay? So, pag genetic na ang involved, ayan, mapapass on na yung insensitivity of the cells to insulin. That will result to mataas na glucose and even mataas na fatty acids. Okay? And then, pag hereditary kasi, sabayan ng obesity, magdahan-dahan masisira din yung pancreas. So, sensitivity plus loss of the cells in the pancreas due to hereditary factors, meron talagang glucose tolerance, impaired glucose tolerance. That will result to diabetes mellitus. Okay? So, basta more than or equal to 126 milligrams per deciliter na yung blood sugar level, possible na yan siya na diabetic. Okay, fasting ano yan siya ha, blood glucose level. So normally dapat less than 115 milligrams per deciliter. 116 to 125, borderline yan siya. Magiging diabetic yan kapag ka ang FBS is more than 125. Okay? Meron din tayong other test na ginagawa for the testing no sa blood glucose level aside from the fasting blood glucose. We also have the random. Kaya lang random is not reliable kasi nakadepende din kung ano yung kinain mo before ka nag-test. Baka ang kaon kag rice imong sudan kay bihon, so puros to siya carbohydrates. So pwedeng tataas din yung blood sugar. Pero yung ceiling natin for the random blood glucose is 200. Pag more than 200 milligrams per deciliter, most probably may problem din tayo nun. Baka may diabetes yung patient. Meron din tayong OGTT. OGTT is oral glucose tolerance test. That's the meaning of the OGTT. Okay? Anong ginagawa sa OGTT? Ang patient pinapainom ng glucose. Okay? Glucose talaga ang pinapainom. And then, after 2 hours, mini-measure yung blood glucose level. If it's more than or equal to 200 milligrams per deciliter, may problem din ang patient. Baka may diabetes mellitus. Okay? So, pwede din yun siyang gawin. Kaya lang, dili lami ang glucose na ilahang ginapainom. Luod siya. And then, ang pinaka-reliable talaga is the HbA1c. Yung atin kasing red blood cells class, didikit kasi dyan yung glucose. Okay? And ang pagdikit ng glucose dyan is pang matagalan. Okay? Pang matagalan yan siya. Excuse me. Kaya kapag magpa-test ka ng HbA1c, tapos yung result is more than or equal to 6.5%, most probably may diabetes mellitus talaga ang patient. And it means matagal na siyang may diabetes mellitus kasi like 3 months na. 3 months nang mataas yung kanyang blood sugar level. Matagal kasi yan before didikit yung glucose. And pag nakadikit, matagal din siyang nadikit dyan sa RBC. Okay? So, dapat lower than 6.5 yung ating result sa HbA1c. Meaning ng FPG, fasting plasma glucose level. Fasting, pwede siya FBS, fasting blood sugar, or FPG, fasting plasma glucose level. Okay? So, yan yung mga test na pwede natin gawin ha to diagnose diabetes mellitus. Do you have questions or clarifications? May nakaligtaan ako na chat. Hindi masyado makita yung chat. Kasi siya nag-notify. Okay. Now, we have 4 categories of diabetes mellitus. So we have the so-called type 1 or insulin dependent. Ito yung mga patients na they no longer produce insulin in their pancreas. Again, that is due to pwede siyang hereditary factors, pero most of the time nasisira yung kanilang pancreas because of viral infection or other types of infection. Yeah. Again, nasisira na siya. And then most of the time, bata pa lang, meron na silang ganitong kondisyon. Okay? So insulin dependent na sila kasi nga yung body nila hindi na nagpo-produce ng insulin. So one example is Gary V. So bata pa lang siya, may diabetes mellitus na talaga siya. Okay, I just don't know paano nasira yung kanyang pancreas. Okay? And then type 2 is the non-insulin dependent DM. So, mostly mga 95% of the cases worldwide ng diabetes mellitus is actually classified as type 2. So, non-insulin dependent, meaning their body can still produce insulin. Kaya lang, it may be their body is insensitive to insulin because of the factors I have mentioned a while ago, yung obesity, and then may mga hereditary factors din, or nagpo-produce yung body nila ng insulin pero kulang. Yan yung reasons, okay? So, we can give them oral hypoglycemic agents like metformin and sulfonylureas. But we can also use insulin sa kanila pag masyado na mataas yung kanilang blood glucose level. Kasi insulin will really help para mapababa yung kanilang blood sugar level. Okay? So sa type 1, insulin lang talaga. Sa type 2, the oral hypoglycemic agent, and we can still use the insulin. Type 3 is Alzheimer's disease. Actually, ang type 3 is yung parang siyang diabetes mellitus secondary to other conditions. Kasi ano lang siya, most of the time, Alzheimer's disease. Now, nag-discuss pa kayo ng Alzheimer's disease sa Pickle 1? Let me check before I continue. Again, nag-discuss kayo ng ng Alzheimer's disease? Oh, okay. So, remember, di ba, Alzheimer's disease is a type of dementia wherein yung sa mga nerve cells, merong mga plaques na tawag dyan, na deposit, and that will hinder the transmission of the message from one neuron to another. Okay, these plaques are actually proteins, small proteins na ma-deposit, okay, again, between neurons. Now, ito kasing mga amyloid na mga proteins na ito na nasa nerve cells or between neurons sa brain, that will also trigger insensitivity to insulin. So most of the time, people with Alzheimer's disease have diabetes mellitus also. So yun. Kaya type 3 is Alzheimer's disease. Again, that's due to the plaques, protein or polypeptide plaques deposited between neurons, or actually pwede ding sa loob talaga ng neurons sa brain. Okay? And then type 4 is gestational DM. Actually, meron yan siya dito sa sa PPT. Sige, balikan ko lang yung iba later. Itong type 4 is diabetes mellitus na gestational. Okay? So there is abnormality sa blood glucose level nila, which is noted first time during pregnancy. Sa mga babae, wala talagang DM before naging pregnant, pero when these people gets pregnant, tumataas yung blood sugar level nila. And that is due to the placenta and the placental hormones. Okay? Yung placenta kasi ng pregnant women, nagpo-produce yan siya ng hormones na nagte-trigger ng insulin resistance. Okay? Nagte-trigger yan siya na maging insensitive yung body to the action of insulin. So usually, in the last trimester of pregnancy. our problem, the oral hypoglycemic agents are not totally safe for the baby, no? Kaya ang binibigay mostly sa mga may type 4 diabetes mellitus is insulin. Insulin ang binibigay sa kanila. Sige. So again ha, type 1, there is B-cell destruction, and then merong severe or absolute insulin deficiency. Okay? Now, ano ba signs and symptoms ng insulin deficiency or yung mataas yung blood glucose mo? Actually, tatlo yan. Polydipsia, polyphagia, and polyuria. And then there is weight loss. I'll explain the weight loss later. Okay? Polydipsia means excessive thirst. Polyphagia means excessive hunger. And then polyuria means excessive urination. And most of this are pronounced sa gabi at night. Sobra na uhaw, and then pirmi gutom, and then masigig pangihi. Ngano man na. Ngano na siya. Wait lang ha, kunin ko lang yung ano. Lugay ko na niwala ng gamit. Akong pen. I will explain that sa inyo. Ngano man na ang mga diabetes, pirmi uhaw, pirmi gutom, and magsigig pangihi. Alright, so screen. Ay, hindi siya nakakonect. Okay. So, di ba? Ano, hindi man siya makagin. Color white. So, di ba? For people with insulin deficiency, mataas ang glucose sa blood. Okay? And then, hindi nila magamit ito ha as a source of energy nila kasi nga hindi siya makapasok sa blood ay sa cell. Now, number 1 kasi glucose is ano siya, osmotically active. Okay? Osmotically active. When I say osmotically active, mag-trigger yan siya ng osmosis kasi glucose is considered a solute. So remember, di ba, pag sinabing osmosis, this is the movement of the solvent, most of the time water, from a region of low solute concentration to an area of high solute concentration. Yan yung movement. Ang water ang mag-move, and then ang movement niya is from an area na konti lang ang solute doon sa area na marami ang solute. Kasi the goal of osmosis is dilution. Okay? So, syempre, the blood, nag-circulate yan siya sa body, di ba? And syempre, dadaan yan siya sa kidneys. Okay? Now, nag-move ang water. Maraming glucose sa blood. Osmotically active siya just like the sodium, just like the asin, the sodium chloride. So, mangyayari niyan, susunod si water dito. Dadami yung volume ng blood. Pag abot niyan sa kidneys, since osmotically active, ito, magsige na siya o urinate. Okay? Kasi nga, marami yung blood, marami yung waste, marami siyang talagang marami yung kanyang urine volume. So, there will be urination. Yan na yung, wait lang ha, erase ko. Mali di ako sila. Pili dapat na. Okay? Pag nag-urinate yan siya, syempre, yan na yung polyuria. Nawala ng pen. Okay? So, ito na yung polyuria. Now, since ang person, sige pangihi, ang iyahang water, giihi na niya tanan, no? Kasi osmotically active yung glucose, ma-dehydrate yung patient natin. So, there will be dehydration. Pag merong dehydration, magre-react syempre ang body. And yan na yung polydipsia. Because of the dehydration, sigig-uhaw ang patient. So, ito yun, excessive thirst. Okay na din yung polyuria. Now, since we cannot use glucose as a source of our energy, walang energy ang body, pero nanginahanglan siya og energy, yan, magti-trigger niya siya sa body na kailangan mo ng source. So, yan na yung polyphagia. Okay? Mag-signal na ang body, gutom ka, kailangan nimo magkaon, wala kay energy. Okay? So kaya ito yung mga signs and symptoms of insulin deficiency. And at the same time, meron talaga yan siyang weight loss. Kasi balik ka pa din doon sa mataas ang blood glucose mo, pero hindi mo siya magamit as a source of energy. So, hahanap yung body ng another source. Ang first niyan, glycogenolysis talaga yan siya. I-break down talaga yung glycogen, yung stored glycogen in the body, pero para ang tawag dyan, magkaroon ng maraming glucose. Pero makaka-add lang yun siya sa increase in the blood sugar kasi hindi pa rin makakapasok itong glucose sa cell. So ngayon, hahanap na ng other source. At dito na papasok ang gluconeogenesis. Okay? Di ba pag sinabing gluconeogenesis, we will be making sugar out from the non-sugar sources. So ang una niyan, ang fats. Ibe-breakdown na yung fats and then gagawin na siyang glucose para may energy, pero hindi pa rin yun siya magagamit. So, sige, breakdown of fats, kaya there is weight loss. Okay? So, kung napansin ninyo, ang mga diabetic people, namamayat talaga yan siya. Pero actually, pag na-control na yung sugar nila, magigain na yan sila ng weight. Pag na-control na yung kanilang sugar. Okay? Do you have questions? Wala. So again, treatment for type 1 diabetes mellitus ha, insulin talaga. Insulin replacement therapy. Okay? Next. Again, ang type 2 ha, merong insufficient or meron ding absence ng insulin and insufficient and sensitivity to insulin ang type 2. So pwede yun siya insulin or oral hypoglycemic agents. Now, itong diabetes ketoacidosis, this is the complication of the type 1 diabetes mellitus. Okay, again, ang diabetes ketoacidosis is a complication of type 1 DM. Okay, now, dito yan siya mag-stem. Saan yun ang pen ko? Suda ni. Nang wala na ko naanad. Mataas ang blood glucose, mag-gluconeogenesis siya. Pag mag-gluconeogenesis siya, ang una niyang source fats, 'di ba? There will be breaking down of fats. Pag i-break down ang fats, ma-release ang maraming fatty acids. Okay. Now, presence of maraming fatty acids in the body class will lead to the formation of ketones, ketone bodies, or we call these keto acids. Okay? I-metabolize kasi ito ng body natin yung maraming fatty acids, tapos yung kanyang product is ketone bodies or keto acids kasi they are acidic. The ketone bodies are acidic in pH. Okay? And pag marami masyadong acid, syempre, bababa yung pH level ng body. The normal pH of the body is between 7.35 to 7.45. But then again, presence of these ketone bodies will lower down the pH. Mas mababa pa sa 7.35. And we all know that it will cause acidosis. So ano na ito? Complication na ito ngayon kapag hindi talaga na-control ang blood sugar, mataas na masyado ang blood glucose level, walang insulin from the outside source, magbe-breakdown ang mga fats sa body, producing fatty acids, and then gagawin siyang ketone bodies, mag-acid na yung body. Acidosis ang tawag dyan. And then acidosis class, pag yung pH ng body hindi siya normal, hindi siya between 7.35 to 7.45, hindi magfa-function yung mga organs natin sa body. Actually, hindi lang organs, magsa-start yan siya sa mga biomolecules natin. Example, amino acids and proteins. The amino acids will not function if linog, nag-shake, wait lang class. Recording. Okay. And then again, type 2 diabetes mellitus, there is again resistance in the action of insulin in the body, or it may be due to deficiency. Okay? It's because, ano yun siya ha, yung sa resistance or yung sa insensitivity ng insulin, again, that is due to a lot of like fats in the body, maging insensitive siya. Okay? So, ang mangyayari niyan, ganun pa rin, ano yan siya, may sequelae yan siya. Yung ating lipid metabolism magiging impaired din basta kulang yung action ng insulin sa ating body. Okay? So, ang treatment natin nito, insulin or the oral hypoglycemic agents. Yung complication, pwede pa rin siya mag-cause ng ketoacidosis ha, 'di ba? Namamayat pa rin naman yung ating type 2 DM patients, and then mag-breakdown pa rin naman yung fats nila doon, so leading to the release of free fatty acids that will in turn become ketone bodies. So kasama pa rin yung ketoacidosis dyan. Pero please take note na ketoacidosis may also occur. Pwede din siya mag-occur as a result of stress such as infection or the use of drugs such as corticosteroids. Kaya kapag inaral natin yung adverse effect ng corticosteroid, kasama doon ang diabetes mellitus, kasama doon ang increased blood glucose level. Okay? And then kasama din doon yung ketoacidosis. Okay? And then ang pinakamarami na complication of the type 2 DM, mas marami ito na case compared sa ketoacidosis. Itong dehydration leading to non-ketotic hyperosmolar coma. Okay? Na-mention ko kanina na kapag maraming glucose, osmotically active siya, mag-move ang water kung nasaan si glucose. Okay? And pag-move sa water, kasama na doon yung pag-increase ng volume ng blood, and therefore mag-increase din ang urine volume. So there will be excessive urination leading to dehydration. And kapag grabe na yung dehydration, pwedeng makomatose yung patient natin. So, ang tawag dyan, non-ketotic hyperosmolar coma. Okay? Pag mag-increase ang blood glucose 6 to 20 times the normal range. So, di ba, the normal range natin is nasa 115 lang if it's fasting. I-times 6 mo yan or i-times 20 mo yan pag naabot gaan ng ganun kalaki or ganun kataas yung blood glucose level, ayun na, makomatose yung patient natin due to dehydration. Okay? Ma-alter yung mental state of the person, mawalan siya ng consciousness. And this is syempre medical emergency and this requires rehydration sa patient kasi nga ang problema natin dito is the dehydration. Okay? So just to differentiate type 1 and type 2, yung onset, usually, sabi ko kanina, type 1, bata pa or at puberty, nagkakaroon na sila ng type 1 DM. Pero yung type 2, usually, sa mga mga of age na patient, usually over the age of 35. Pero ngayon, meron tayong mga diabetic patients na type 2, tas bata pa, and that is maybe due to the lifestyle. Okay? Central obesity, ganon. Okay? Kaya dito, nutritional status, at the time of onset, there is usually obesity present for type 2 DM. Pero sa type 1, they are usually undernourished. Okay? And then sa prevalence na sabi ko na kanina, 90 to 95 diagnosed diabetics are type 2, the remaining 5 to 10 are type 1. Okay? Genetic predisposition, moderate lang yung sa type 1. Yung pagkasira ng kanilang pancreas is usually due to stress and infection, pero very strong ang genetic predisposition for the type 2. Okay? Sa defect or sa deficiency, again, B cells are really destroyed for type 1, kaya hindi makaproduce ng insulin. Sa type 2, pwedeng there is deficiency, hindi masyadong makaproduce. Nagpo-produce pa rin pero kulang. Okay, for the type 2 DM, and then there is insulin resistance. Yung sa type 3 DM, sabi ko kanina, Alzheimer's disease, but it may be due to other diseases. Pwedeng secondary to, example, pancreatectomy. Pag sinabing pancreatectomy, inalis ang pancreas. Kapag wala ng pancreas, wala talaga mapoproduce ng insulin, and the patient may develop DM. That will be under the type 3. Okay? Pancreatitis, inflammation of the pancreas, and there are also non-pancreatic diseases that will lead to elevated blood glucose also. So magiging secondary yung insulin deficiency. And then there is also drug therapy, like the use of the long exposure to corticosteroids can lead to increased blood glucose level. And then again, Alzheimer's disease. So type 4 tapos na ito kanina. Questions before we'll move on to the drugs? Yes, Archie.
Ma'am, under what type po yung like magsugat dito ma'am tapos dugay siya mag-heal?
Yung magsugat tapos matagal mag-heal, that is a complication of diabetes. Okay, maraming complication yung diabetes natin. Wait lang ha. So, like, asan na? Magsulat ko. Complications, ito ha, ang isusulat ko. Complications. Nasabi na natin kanina yung ketoacidosis. And then, meron din tayong yung comatose, yung ketotic hyperosmolar coma. And then, number 3, neuropathy. Yung neuropathy class, yung kanilang mga nerve cells, madadeposit kasi doon yung maraming sugar. And then, pag na-deposit yun, their nerves will become insensitive. Therefore, ano yan sila, magiging insensitive din sila sa pain. Merong mga diabetic patients na pag nag-neuropathy na sila, makaapak sila ng thumbtacks, dili sila masakitan, wala silang ma-feel. That is again because of the too much glucose that are being deposited in the nerve cells or the neurons. And then, we also have, before mag-retinopathy, and yung mga glucose na na-deposit doon sa nerve cells, aside sa wala silang ma-feel na pain, is yung neurons nila maging insensitive and then mag-slow down yung healing process. Kaya kapag ka nasusugatan sila, hindi agad-agad nag-heal yung kanilang wound. Okay? And it will result to death of the tissues itself. So, mag-result yan siya sa gangrene. Okay? Gangrene. Pag kanaganing namatay ng tissue mag-itom, mauna na siya, and then there will be the risk of amputation after. So, yan, hindi yan siya sa types, but a common complication of an elevated blood glucose level. Pag hindi talaga siya um, i-treat, hindi din siya ma-treat, i-ano lang siya, ipa-normalize lang siya, i-regulate. And then retinopathy, yung sugar, aside sa mag-deposit siya sa nerves, mag-deposit din yan siya sa nerves sa mata. So, kaya may mga diabetic class na pag grabe na talaga, long time na hindi na-regulate yung blood glucose level nila, na sila, mabuta sila. Okay? Yan siya, retinopathy. And then, problems in the heart and the kidneys. Because remember, na siya, nasa blood yung glucose, tapos, syempre magiging malapot yung blood, no? Kasi marami masyadong sugar. And then at the same time, sabi ko kanina, osmotically active yung glucose. So, pupunta din doon yung water. So, ang tendency, dadami yung blood volume, and then malapot pa talaga yung blood, mahihirapan yung heart magtrabaho, and then it will lead also to the increase in the blood pressure, and mahihirapan din mag-work yung kidneys. Kaya magiging triad yan silang tatlo. So yung people with diabetes may have heart conditions also, or kung hindi heart condition, pwedeng mataas yung blood pressure, and then meron din silang kidney disease. Okay? Magiging complication na yun siya. Okay? Any other questions? Yes, Marie.
Possible po ang pancreas transplant.
Pancreatic transplant? Wait lang.
Yes po.
I haven't seen a case of pancreatic. Pero I think meron. Meron ata. Let's check. Oh yeah, possible. Though I haven't read a case about pancreatic transplant, pero meron siya. That is a treatment option for people with complications of diabetes na mahirap talagang i-control ang blood sugar nila. So, nagiging option yung pancreatic transplant. Pero usually, diabetic people don't really need a transplant. Yung iba sa kanila, kaya lang kasi talagang i-control with oral hypoglycemic agents and insulin. So, option siya pero hindi siya common. Okay? Anything else? Wala na. So, let's talk about the first one, the insulin. Kasi ito naman talaga ang reason bakit may diabetes mellitus. So, insulin, again, is produced by the beta cells of the islet of Langerhans. It's a protein. It's a small protein. Hormones are also protein, ha? So, it's a protein. It's small, thus the molecular weight is just 5,808. Okay? Now, since it is a protein, so definitely it is composed of a lot of amino acids. It actually contains 51 amino acids arranged in 2 chains. So, dalawang chains ng amino acid, ha? Dugtong-dugtong na amino acid, tapos dalawang chains. And these 2 chains are linked together by disulfide bonds. Okay? Yan yung bond or yung linkage or yung bridge between the two chains of amino acids ng ating insulin. Okay? Now, pag nagawa na yan siya, it will be stored in the B cells as crystals. Okay? And this is a board exam question. Pag-store siya ng body natin sa pancreas as crystal, meron yan siyang zinc. Kaya kailangan din ng body yung zinc ha. Kasi pag magka-problem tayo with the amount of zinc in the body, magkaka-problem din tayo with the amount of stored insulin natin sa pancreas. Okay? So again, it consists of, pag naging crystal na siya, it consists of 2 atoms of zinc and 8 molecules of insulin. I-link sila together. That's how we store the insulin in the B cells of the pancreas. Okay? In a question to sa board exam, anong metal ang involved in the storage of insulin? That's zinc. But before yan siya naging insulin, it is called proinsulin. So ito yung parang precursor, yung raw material ng ating insulin. It's still a protein pero single chain pa lang siya. Okay? And ginagawa yung insulin inside the cell. It's the Golgi apparatus of the beta cells na produce ng proinsulin, gina-package siya into granules. Pag ma-hydrolyze na yung proinsulin, ito na yung magiging insulin na talaga siya. Okay? When I say hydrolyze, mag-undergo siya ng hydrolysis, ma-remove ang 4 na amino acids doon and then malink na siya with the disulfide bridges, yung dalawang chains, kaya maging insulin na yun siya. Okay? Pero again, inside the beta cells, ito pinoproduce via the Golgi apparatus na pinapackage siya into granules. Pag na-hydrolyze na, maging insulin na, and then pag na-release from the beta cells ng pancreas, pwede na natin siyang gamitin sa body. Okay? Now, kailan marirelease yung insulin? Kasi 'di ba sinustore siya sa pancreas. Okay? Marirelease siya at a low basal rate in a response to a variety of stimuli. Sample, glucose. Pag maraming masyadong glucose in the blood, that will trigger the pancreas to produce insulin. Actually, class, pag hungit pa lang nimo sa pagkaon, as in seconds to minutes pa lang na natulo nimo imong pagkaon, mag-produce na ng pancreas, mag-produce na ang pancreas ng insulin agad-agad. Ganun kabilis ang action ng pancreas. Okay? And it's not just glucose. Other sugars will also trigger the release of insulin from the pancreas. And aside from sugars, amino acids like leucine and arginine will also trigger insulin release. And then there are also other hormones that will trigger release of insulin from the pancreas like GLP-1, GIP, glucagon, cholecystokinin, and the vagal activity of the heart. Okay? Okay. However, merong mga trigger, meron ding inhibitory signal. So itong mga inhibitory signals, syempre mag-inhibit ng pag-release ng insulin from the pancreas. So nasabi ko na ito kanina, somatostatin is an inhibitory hormone. Pag meron ka nito, marami nito, mag-i-inhibit yan siya ng pag-secrete ng mga glands natin. Leptin is another one. And ito talaga, take note, chronically elevated glucose and fatty acid levels. Pag nag-increase ang blood glucose at hindi talaga siya kinontrol, chronically mataas ang sugar ng body, magiging inhibitory signal siya sa pancreas na hindi na mag-release ng insulin. So, musamot ang condition sa patient. Magsamot ang iyahang elevated glucose level. The fatty acid levels also. Magiging inhibitory signal din yan siya na hindi na mag-release ng insulin ang pancreas. And then, insulin degradation happens in the liver and the kidneys. Okay? Mametabolize siya. Masisira lang din yung body, yung sa body natin, masisira lang din. Ida-destroy lang din ng body natin yung ating insulin via the liver and the kidneys. Kasi nagme-maintain tayo ng normal levels of insulin in the body. Ito yung normal levels natin. Okay? 5 to 15 microunit per ml, or kung P-mol per liter, that's 30 to 90. Now, during meals, mag-peak yung ating insulin up to 60 to 90 microunit per ml. Okay? Now, other things that will regulate the increase of the insulin in the body, we have hormonal agents like yung mga corticosteroids natin or glucocorticoids. So, pag magsigig take of corticosteroid, this will lower the affinity of insulin receptors for insulin. So, si insulin, pag na-release yan siya sa body, may receptor din yan siya sa cell. Pag nakadikit yan siya doon sa receptor niya, yan yung time na mahe-help niya yung glucose to enter the cell. So, pag hindi yan siya nakadikit, hindi yan siya nagkaroon ng interaction sa kanyang receptor, then wala din siyang action. And that will be, again, lowered. The affinity will be lowered through the use of corticosteroids. So be careful with the use of corticosteroids, ha? And then, growth hormone in excess will increase insulin affinity. In excess lang, ha? We all have growth hormones. But pag excessive na ang growth hormones, yun, mag-increase naman ang affinity ng insulin sa receptors. Okay? Questions before we'll be talking about the effects of insulin in the body? Any question? Wala? Wala, sure na. Now, let's talk about the effects of insulin in the body. Number 1, effects on the liver. Pag maraming masyadong insulin, it will reverse the catabolic features of insulin deficiency. Okay? I-reverse. Sabi ko kanina sa catabolism, it's breaking down of larger molecules to smaller ones. Okay? Pero ito, pag may insulin, ma-reverse, ma-inhibit yung pag-breakdown ng malalaking molecules. Kaya, ito yung mga examples na ma-inhibit niya. Ma-inhibit niya yung glycogenolysis. Diba? Remember, glycogen is a big molecule na sinustore natin sa liver. And then, ma-inhibit yung glycogenolysis. Hindi mag-breakdown yung ating glycogen. So, mas maraming sugar na marirelease sa blood. Ma-inhibit din ang conversion of fatty acids and amino acids to keto acids. Okay? Kaya walang ketoacidosis. And inhibits conversion of amino acids to glucose. This means inhibits gluconeogenesis. Okay? Now, ang anabolic action naman, kasi sabi ko kanina, yung ating insulin is more on the anabolism. Okay? Pag anabolism, yung mga smaller molecules, mag-build up siya into larger ones. So, pag merong insulin, it will promote glucose storage as glycogen. So, aside na ipapasok niya yung glucose sa cell, yung mga excessive glucose na na-intake natin, mag-trigger yan siya ng glycogenesis. Ang kabaliktaran ng glycogenolysis ay glycogenesis. So, mag-promote yan siya ng storage of glucose as glycogen in the liver or pwede din sa skeletal muscles. Kasi glycogen are stored there, either in the liver or in the skeletal muscles. And then increased triglyceride synthesis in the VLDL formation. Yung mga VLDL na napoproduce natin, for example, in the liver, will become triglycerides. Triglycerides are bigger molecules. So, anabolic yun siya. Anabolism. Okay, now how about effect of insulin in the muscle? So there will be increased protein synthesis. Anabolic kasi talaga yung action niya. Kaya mag-i-increase yung activity ng amino acids leading to the increase of the protein synthesis. Especially in the ribosome kasi doon naman talaga tayo nag-synthesize ng protein. And sabi ko na din kanina, there is increased glycogen synthesis. So glycogenesis, not just in the liver, but also in the skeletal muscle. Now, how about effect on adipose tissues? There will be increased triglyceride storm. Ano, ingon ko kagaina class, pag ang diabetic patient na control niya na ang sugar, di ba, nag-gain weight lang din kasi anabolic yung action ng ating insulin, kasama doon ang pag-produce ng triglycerides. And going back to our previous lesson, pag sinabing triglycerides, we are talking about fats and oils. So magpo-produce ng maraming ganito and madedeposit sa adipose tissues. Okay? So mutambok in short. Questions? Na-activate yung lipoprotein lipase and then yun na, produce ang maraming triglyceride. Pero ma-inhibit yung intracellular lipase, so hindi magbe-breakdown inside the cell, masustore lang talaga siya. Before we'll take a break, let's talk about characteristics of available mahaba ito. Mag-break na lang muna tayo kasi 11:57 na pala. Again, mag-break muna tayo. 30 minutes, mga ano lang sa take. Kung ako ani siyang sugdan, mabitin ko. Daghan kayo itong insulin preparations sa market. Okay? Okay, let's continue. Let's have the characteristics of the available insulin preparations. Now, please take note of this. We have here the following principal types of our insulin preparation, and they are classified according to their duration of action. So number 1, rapid acting with rapid onset and at the same time short duration na insulin preparation. Ganyan lang yung pag-divide natin pag-classify natin sa insulin. So 4 lang yan, rapid acting. Mabilis ang onset pero short duration. Meron din tayong short acting. Short ang kanyang duration pero slower yung onset compared to the rapid acting ones. And then we have intermediate acting and the long acting with slow onset of action. So sa long acting, matagal yung kanyang onset, matagal yung kanyang effect mag-start, but matagal din yung kanyang duration of action. Now, these are board exam questions. Itong mga properties of the different insulin preparations natin. Yung rapid-acting and short-acting insulins natin are dispensed as clear solutions. Again, they are clear solutions and then they have neutral pH. And then, just like how we store insulin in our pancreas, meron din itong small amount of zinc and the purpose of the metal is to stabilize, okay? For the stability of the preparation para hindi siya madaling masira. Therefore, mas matagal yung kanyang shelf life. Okay, that's the purpose of zinc, which is added in the rapid-acting and short-acting insulin preparations. Pag meron din tayong intermediate acting or the NPH insulins. Okay? Ang ginawa naman dito, lahat sila ha-injected. So hindi lang ang intermediate. Ano din, ang short acting and rapid acting din. Wala tayong oral preparation for our insulin. Now again, ang intermediate acting may minodify doon sa amino acid sequence para ma-modify din ang kanyang appearance and then especially ang minodify ang kanyang pharmacokinetic profile. Okay? So, ito naman ang kanyang physical appearance, turbid. Turbid siya na suspension, neutral pa rin ang pH. So, ang dinagdag here is the protamine in phosphate buffer. Okay, kaya tinawag siyang NPH, insulin. They are intermediate acting. And itong last, si glargine and detimir, ito yung mga long-acting insulins natin. Ha? Glargine, insulin glargine and insulin detimir. They are clear also, and then soluble long-acting na preparation. So almost the same na appearance sa rapid and short acting. They are also clear. Clear in appearance, but the pharmacokinetic profile is different. This is a long-acting na preparation. Okay? So let's discuss them one by one, yung mga insulin preparations natin. Number 1, we have here the rapid-acting insulins. You will see a lot of this in the community pharmacy and the hospital pharmacy. The insulin Lispro, brand name yang nakalagay sa ano ha? Sa open and close parenthesis. Deglodec is under the long-acting. Okay, please take note. Insulin Deglodec is under sa long-acting insulin. Yung rapid-acting insulins natin, again, we have insulin Lispro, that's Humalog, insulin Aspart Novolog, and the glulicin, the insulin glulicin, that's the Apidra. Yung nilagay dito, yung mga mostly used na brands ng ating rapid-acting insulin. Okay, now, paano natin ina-administer itong rapid-acting insulin natin? They are injected subcutaneously. Please take note, they are injected subcutaneously. Now, kailan siya i-inject? This is taken immediately before the meal, before the meal ng patient. Example, kakain siya ng 7:30. Before dyan siya mukaon, mag-inject na subcutaneous sa ato ang rapid acting. The purpose is para pag nagkaon siya, there is no ang tawag dyan, postprandial elevation of the blood glucose level. Pag sinabing postprandial, yung after kang kumain, syempre pag after tayong kumain, mag-i-increase man talaga yung ating blood sugar level. Ang problem with diabetic patients, sobrang taas yung kanilang blood sugar after eating, no? So since this is rapid acting, pag humanjud nila og kaon, there will be insulin replacement, okay, using this Apidra. So, kada kaon nila, I mean, pamahaw paniud to panihapon. Most of the time, this is administered 3 times a day. So, sa buntag, before sila mamahaw, sa udto na po, before sila maniudto, and then sa hapon, before sila mag-dinner. Okay, before talaga mag-eat, para walang postprandial na increase, too much na elevation of the blood glucose level. The purpose of this is just to mimic the normal amount of insulin. Kasi sabi ko kanina, di ba, pag hungit pa lang nimo, seconds or minutes nga nakasulod ang food sa imong body, mag-release na kaagad ng insulin yung pancreas. So, ganito yung ginamimik ng mga rapid acting na pag humanog ka o naa na dayon insulin replacement. Okay? Nasabtan? So, insulin Lispro. Yung mga pangalan actually nitong mga rapid acting insulin is dependent on the amino acids involved. May mga amino acid na ni-replace, may mga amino acid na ni-reverse. So kagaya ng Lispro, from the name itself, Lispro, makikita nyo na kaagad na the amino acids that are being modified here from the normal na amino acid sequence of the human insulin is si lysine, and then pro is proline. Kaya siya tinawag na insulin Lispro. So all of them are products of recombinant DNA technology. Pero for insulin Lispro, the position of the proline and the lysine are reversed in the original amino acid sequence. Binaliktad silang dalawa. Okay, si proline and si lysine. Kaya siya tinawag na insulin Lispro. Okay, nung binaliktad silang dalawa, ang resulting product nun is a rapid acting, mabilis ang kanyang action. Naglisod mo upang ita sa hospital pharmacy na time. Ang Lispro, mahirap hanapin. Wala sila mga stocks. Mahal ang insulin class. And then the production, kaya siya mahal, the production, hindi din basta-basta. Again, this is recombinant DNA technology. Kaya wala sa pangalan. Kasi wala sa pangalan. Kasi wala sa pangalan. Ang brand. Ano ba? Dili connected ang generic name. Oh, yeah. As you can see, wala sa yung box. Insulin Lispro, that's Humalog. Okay? Hindi sila connected. Again, Lispro is Humalog, ha? Now, we have insulin aspart. Okay, from the name itself, aspart. Anong amino acid yung may aspart? That's aspartic acid or the aspartate. So, ito naman, di ba sabi ko kanina ang insulin, dalawa ang chains. So, meron tayo, ang dalawang chains na yan are called A and B. So, ang minodify dito sa insulin aspart is the B chain, the number 28 na amino acid sa B chain is substituted with a negatively charged aspartic acid. So, since aspartic acid yung dinagdag doon sa B28 ang gisubstitute, they called it insulin aspart. So again ha, aspart is novolog. Lispro, Humalog, aspart, novolog. And then the glulisin is apidra. Okay? So look at the name, glulisin. So ang nangyari dito, nag-substitute ng asparagine for lysine, kaya siya may lysine dyan, that's lysine, at the B chain, number 3 na amino acid, and then glutamic acid for lysine at the B chain pa rin, pero number 29. So parehas na lysine yung pinalitan, okay? Dalawang lysine kasi ito, like ang B chain, ang number 3 na amino acid originally is lysine, ang number 29 is still lysine. Pero pinalitan siya. Ang B3 ang pinalit is asparagine, tapos ang sa B29 ang pinalit is glutamic acid. Pero yung nasa name lang is the glulisin. It's glutamic acid and then the lysine. Okay, again, this is the apidra. Ano ito? Short acting. Short acting. Rapid acting. Kailan siya ibibigay? Before magkaon. Okay? Ang ato ang patient. And then paano? It's subcutaneous. Okay? Those are the rapid acting insulin tapos short duration ang action. Okay? Now, the second type or the second group is the short-acting insulin. So, ito yung mga short-acting. The regular Novolin R, or we call it the Novo-Nordisk, and the regular Humulin R. Novolin R and Humulin R, ha? R means regular, actually. Novolin R, Humulin R. Okay? Short-acting sila. Slower lang yung onset. Mas mabilis lang talaga yung kanina, yung mga apidra. Okay? Now, take note, si regular insulin class, this is a board exam question. Bakit? Kasi among our insulin preparations, ito lang yung binibigay, pwedeng ibigay IV. Kasi 'di ba, while ago na mention ko na binibigay ang insulin subcutaneously. So merong IV preparation ang ating insulin, and that is the regular insulin. Okay, they are short acting, ha? Short acting ito. So, ganun pa rin, meron pa rin itong zinc sa preparation, and this is also made via the recombinant DNA technology. Now, kailan siya ibibigay? Before meal pa rin. At least 3 to 45 minutes before meal. May time tayo dito ha, kasi 'di ba slower ang kanyang onset of action. Hindi kagaya ng mga glulisin and then the lispro and the aspart kanina, pag inject mo talagang mabilis ang action. So kahit before sila mukaon ihatag nimo, okay lang. Ito 30 to 45 minutes to allow time for the onset of action, para pagkaon sa patient nag-effect na din itong regular insulin. So yung itong purpose nito is the same thing to prevent postprandial increase in the blood sugar level. Again, pag sinabing postprandial, pagkatapos kumain. Prandial means kumain tayo, post pagkatapos. Okay? Now, intermediate acting insulins. Ito yung may mga NPH. So, may humulin and novulin pa rin ha. Do not be confused, kasi yung short-acting novulin and humulin din yon. Pero yung kadugtong R. R means regular. Ito naman, the intermediate acting insulin, N. Humulin N and novulin N. So, NPH, humulin, and the NPH, novulin N. Intermediate acting sila. Slower pa rin ang onset of action, pero mas mahaba ang duration of action compared to the regular ones. Okay, intermediate acting insulin. And then in the market, we have premixed insulins. Gimix class. Gimix ang rapid acting, short acting, and the intermediate acting. Okay? Ang purpose is para mabilis yung action, mabilis yung onset of action, and then mag-increase yung duration of action. Yan yung purpose of the premixed insulin. For example, ito, novulin 70% ang NPH, 70% ang intermediate acting, and then 30% ang short acting, that is the regular. So novulin 70-30. Yan yung tawag nila. And then humulin 70-30. Okay, so may 30% siya na short-acting insulin para mas mabilis konti yung kanyang onset of action. Pero since meron siyang intermediate-acting na content, so mas mahaba yung kanyang duration of action. Okay, so we have NPL, Lispro, depende sa hati-hati ba sila, 50-50, 75-25, and then the NPA 70 na NPA, and then aspart is 30. Okay? So yan yung mga premixed insulins natin. May content siya na either rapid or short-acting insulin, and then the intermediate ones. So pag sinabing NPH, okay, NPH means neutral protamine hagedorn, or we call this isophane. So baka ma-encounter niyo siya, it's either called NPH insulin or the isophane insulin. So ito, pag dinagdag siya sa insulin preparation, it will delay the absorption of the insulin. And that will mean na delay din ang kanyang onset of action, pero it will have a longer na duration of action. Okay? Yan yung NPH insulin natin. Questions or clarifications? Wala, sure na. Now, moving on, let's talk about, yes, Florence.
Ma'am, ask lang po, ma'am, ano po ang difference ng regular and insulin? If may difference po sa structure, bakit siya lang po ang pwede ma-administer IV?
Bakit? Huh?
Bakit yung regular insulin lang po ang pwede ma-administer IV, other po kay subcutaneous na po?
Bakit siya pwedeng i-administer IV? Yung
Yes
kanyang
po.
molecule is smaller compared to the other, ano sa tawag na, the other formulation of insulin. Okay? So, mas pwede siyang i-administer, hindi siya masakit, and at the same time, i-adjust ang kanyang tonicity, in-adjust yung tonicity neto para pag i-inject mo siya sa blood, same lang yung kanilang salt content. 'Di ba pag sinabing tonicity, it's the amount of salt in the preparation. So, pag in-adjust mo yung tonicity ng yung preparation, dapat same sila ng isotonic siya with blood, in short, para pwede siyang i-administer. Yung iba, pwede siya subcutaneous lang talaga. So, pag in-inject natin yun sa kanila, masakit yun. And then it will, 'di ba, sa inyong biochem, I believe nag-discuss kayo ng effect ng isotonic, hypotonic, and hypertonic preparations. So itong mga insulin na ito, yung yan, amino acid sequence na gi-substitute or gi-reverse, yun, ang product nun, yun yung magdidictate kung gaano kalaki ang kanyang molecule and gaano kabilis ang kanyang action, and at the same time, gaano katagal ang kanyang duration of action. Yan siya. So
Thank you po.
it's all in the number one, in the structure, the makeup of the sequence of the amino acid. Ganun yan siya. Okay? And then the long-acting insulins. We have the insulin detemir and the insulin glargine. Pakidagdag si deglodec. Wait, itong i-type. Isulat diri, ikatulo. Insulin. What's the brand name of deglodec? I forgot. Ano siya? Dili gyapon ko kahinumdum sa mga brand names class, pero before my father died, deglodec yung sa kanya. Nakalimot hinoon ko sa brand. Do you know the brand?
Tresiba po, ma'am.
Ha? Ano sa to?
Tresiba po. Tresiba.
Tresiba, yeah. Very good. That's Tresiba. Again, it's Tresiba. Pakidagdag yan siya, ha. And then the insulin glargine, that's the Lantus. Maraming gumagamit ng Lantus, no? When I work sa pharmacy and yung intern ako, marami ito. Pero hindi siya mabusan. The Lantus Solostar. And the insulin detemir, that's the Levemir. Okay? Delete natin. Now, board exam question na naman. Si insulin glargine, that's the Lantus, ha? Ito yung peakless na insulin. Board exam question yan siya. Ito, mag-draw tayo para you will have a picture of what a peakless insulin is. Ay. This one. Diba sa di man pa kay straight. Wait lang. Okay. Diba sa biofarm ninyo, nag-discuss kayo ng AUC, area under curve. Sample like this one. So, i-administer mo siya. Tapos, syempre, yung plasma concentration niya, dito, this is the plasma concentration here, this is the time here. So, syempre, aakyat yan siya as time goes by. And then, ma-achieve mo yung Cmax, the maximum concentration at a certain time. So, at a certain time, that's the Tmax. And then, after that, syempre, ma-eliminate ang drug sa body. Okay? Kaya bababa na siya dyan hanggang maubos yung drug sa plasma. Now, pag sinabing peakless insulin, ganito siya. Wala siyang peak. Therefore, wala siyang Cmax. Okay? Ganito lang siya, plateau. Okay? Plateau siya. Para siyang may steady state concentration, ganon. Achieve mo yung steady state niya. So, kaya tinawag siyang peakless. Okay? Plateau lang siya. So, long-acting ito ha. Matagal siyang mag-plateau dyan sa plasma. Maraming insulin sa plasma na mag-stay siya and is available for the action. Okay? Hindi mabother ko sa mabatian ako akong tingog sa background. Hindi ko concentrate. Okay? Sige. Questions? Hindi lang ah. Yan. Sorry. Mabatian ako akong tingog, mabother ko, dili ko makaisip unsa ako sultin. Pag ano, drabe. Hindi nakakadungog. Pag headset. Okay. We have next. The insulin detemir. Okay, so again, the insulin detemir. So this one is actually this is not the recently developed, it's the degludec. Pero when the book kasi was made, detemir pa kasi yung recent na develop na long-acting insulin. The recent one is the degludec. Pero parehas silang long-acting. Now, paano natin produce yung insulin? It's through DNA, recombinant technology, wrong spelling, recombinant. This is recombinant DNA technology. Now, anong ginawa nila? Nag-extract sila ng insulin from human, as in from human pancreas, in-extract ang insulin. And then, after that, insert ang DNA ng insulin ng human doon sa modified din na E. coli and or yeast, the brewer's yeast, anong scientific name? Saccharomyces cerevisiae. That's the scientific name of the brewer's yeast. Sulat na to. Saccharomyces cerevisiae. Okay? Scientific name yan ng yeast ha. So, bakit sinabi kong modified? Kasi ito yung mga strains na hindi siya nagkukos ng sakit. Especially the E. coli. Tapos, syempre, in-insert doon sa DNA nila. And then, syempre, we know that bacteria are actively dividing. So, nagadami din yung DNA sa loob nila. Tapos pag marami na siya, hina-harvest yan siya. Ini-extract siya ulit in its pro-insulin na form and then ginamodify na, doon napapasok yung modification na i-exchange yung mga amino acids o kaya i-substitute to make it the insulin that we know. And then i-modify siya para different sila depende ko ano yung goal nila, different yung onset and duration of action. So again, ang tawag doon, recombinant DNA technology. So hindi basta-basta yung pag-produce ng ating insulin, kaya din siya medyo expensive. Okay, expensive ito. Dati, as in yung wala pang recombinant DNA technology, ang ginagamit na insulin for human, for patients with diabetes mellitus is insulin from pigs. Okay? as in sa baboy na insulin. Kaya lang, ang problem with using the insulin sa baboy, since though insulin pa rin siya, pero syempre may difference din sila sa structure, sa amino acid na sequence. So magkakaroon yan siya ng action, I mean, parang sa immune system, may response ang immune system sa body. So some may be allergic to the insulin ng baboy, some may be insensitive to it, so wala ding actions, and kasali din doon yung religious na concerns. So example sa mga Islam, and then yung insulin is galing sa baboy, they will really not be into it. So hindi nila yon siya gagamitin kasi nga galing siya sa baboy. So kaya when the recombinant DNA technology was developed, all our insulin products nowadays, doon na siya galing. Hindi na tayo gumagamit ng insulin sa baboy. Okay? Now, insulin delivery, wait lang, erase natin. Insulin delivery systems, yung dinidispense ninyo are portable pen injector. So, nagpapalit lang ng lancet or ng needle para ma-inject. Siyempre, papalitan talaga ang needle kada inject. Kung papasaw na before siya namatay, kaupat siya mag-inject sa isa kaadlaw. Meron siyang apidram siguro to. Meron siyang rapid acting na ina-administer before siya magkaon, and then meron siyang isang long acting, that's the degludec, it's for the whole day. So imagine the 4 katusok sa isa kaadlaw, and then every day yun siya for na administration. Okay, kaya kailangan talaga siyang ang tawag dyan, hindi dapat paulit-ulit na site. Okay? Pero yung iba, meron silang continuous subcutaneous insulin infusion devices, or we call that insulin pumps. Yung kay Gary V, I know nasa belt niya yung pump niya. So like continuously sa body niya naga-inject ng insulin. Hindi siya magtusok as in parehas sa 4 times a day. Na talaga sa kanya, parang infusion device siya. So isa-set lang ang amount ng insulin na i-administer from time to time. Para siya ang dextrose nga, ganun. Yung sa kay Gary V lang nasa belt niya. So, hindi mo pa din kita kahit nasa belt niya. Even during performing, nasa belt niya yun. Okay? Now, insulin regimen. So, oras na. Basig masobrahan ko. Pag 1:30, papasukin natin yung section B. Insulin regimen. So, we have here intensive insulin therapy. Wait lang. Intensive insulin therapy. So, this is total daily insulin requirements in units is equal to weight in pounds divided by 4. Yan yung supposedly insulin requirement natin sa body. So, ilan yung weight nyo in pounds, i-divide nyo yan sa 4, that's the amount of insulin na kailangan. So, the Miller snack and high blood sugar correction boluses are prescribed formulas. Okay? May ibang computation pa, may dagdag pa, depende kung elevated talaga yung sugar for a long time, o kaya depende din sa kinakain. Okay? Sa intensive yan siya. Sa conventional insulin therapy, ito yung pwedeng ibigay sa mga type 2 diabetes mellitus patient. Kasi, 'di ba, yung sa type 1, most likely intensive yon. Sa type 2, pwede siyang meron silang oral hypoglycemic agent, tapos dagdagan pa ng insulin. Okay? Especially if ang assessment ng physician is hindi talaga na nag-e-effect yung oral hypoglycemic sa kanila. Kahit umiinom sila, hindi bumababa yung kanilang blood sugar, hindi makontrol. So, nagdadagdag ng insulin. Okay? And then insulin treatment of special circumstance, ito na yung mga patients natin na merong complications. Kagaya ng patients na nag-experience na ng diabetes, ketoacidosis. So, na-discuss ko na to kanina. Sabi ko, pag very elevated yung blood sugar, walang energy yung body, so maghahanap ang body ng another source of energy. So mag-gluconeogenesis, and the number one source are the fats. It will be broken down, and then as they break down, they will produce free fatty acids, and the free fatty acids will be converted into ketone bodies. These ketone bodies have acidic pH, making the body acidic also. So the patient may experience diabetes ketoacidosis. Okay, yung mga organs, yung mga biomolecules sa body, hindi yan siya magfa-function if hindi nakapasok sa normal range ang pH ng blood, okay, or ng body. But diabetes ketoacidosis occurs more on type 1 patients than in type 2. Mas marami yung nag-ketoacidosis sa type 1. So ito yung mga signs and symptoms of having ketoacidosis. Yung nausea and vomiting, given yan siya. The abdominal pain, ito talaga basta, hindi lang itong deep slow breathing, hindi lang ito sa mga may diabetic ketoacidosis. Pag may acidosis ka talaga, ganun yung paghinga mo. Okay? As in, hugot jud, and then slow. And then the mental status may be altered. Syempre, there is elevated blood and urine ketones and glucose also. And then since arterial blood pH, ang arterial blood pH nito is higher than 7.3. When I say higher, hindi yun siya 7.3, 8, 14 ha. Yung sa acidity ang tinitingnan natin, the more ka na mag-1, ganon, the more acidic yun siya. Okay? So, low ang bicarbonate, kaya nag-aacidosis. Okay? And then, hyperosmolar hyperglycemic syndrome, ito naman yung mas common sa type 2 patients. Ito yung hyperosmolar coma na sinasabi ko kanina, na 'di ba mag-dehydrate yung patient with diabetes kasi osmotically active ang glucose. So pag masyado nang mataas ang kanilang blood sugar level, ma-dehydrate sila and pwede silang ma-comatose. Okay? Na especially if may iba pa silang condition, tapos may ibang gamot pa silang tinitake, just like phenytoin, steroids, and especially diuretics, mosamot pag yun. Especially if may diabetes sila, tapos may sakit din sila sa heart, binibigyan sila ng diuretic, mosamot pa dyan sila ka-dehydrate. So, mas mataas ang chance for dehydration, for comatose doon. And then beta blockers and hemodialysis. Now, what are the complications of the insulin therapy? In short, mga adverse effects nito, side effects. Number 1, it's hypoglycemia talaga. Pag masobrahan ng insulin, talagang bababa masyado ang blood sugar level. And how will you know na masyado nang mababa ang blood sugar level ng patient? Number 1, meron yan siyang simpa and parasimpa na effect. For sympathetic na effect ng mababang blood sugar, we have your tachycardia, magpapalpitate yung patient. Kaya nga 'di ba sa mga exams natin, kasali doon, bakit hindi dapat, or kung gagamitin man ang beta blockers for diabetic patients, dapat i-monitor. Ito yon kasi beta blockers, di ba, can slow down the heart rate. Therefore, it will mask the hypoglycemia. Hindi mo na siya makikita na nag-hypogly pala kasi instead of tachycardia or palpitation, natambalan na siya sa beta blockers, nagbaba na yung kanyang heart rate. And then we have sweating also, and then tremor. Okay? For parasympathetic na effect of the hypoglycemia, the patient may be nauseous and at the same time gutom. Pag grabe na talaga, kababa ang blood sugar level, it may lead to convulsion and then comatose also, and then death. So mahirap din kung mag-hypogly ang patient. Kaya kino-compute talaga kung yung pen natin sa I don't know if you have tried administering the portable pen injectors ng ating mga insulin. Ano yan siya? Meron din yan siyang certain dose per units ang nakalagay dyan. So, kino-compute din yan kung gaano karaming units ang i-inject per administration para hindi din mag-hypogly yung ating patient. Okay? And then, we have here immunopathology of insulin. Though meron pa rin yung sa bovine or yung sa mga pigs na insulin, yun talaga mataas ang case for hypersensitivity. Pero meron pa rin nag-occur na insulin allergy nowadays even if galing na sa human insulin yung na-administer natin. Okay, so this is a rare condition though in which local or systemic urticaria results from histamine release from tissue mast cells sensitized by anti-insulin IgE antibodies. Meaning yan, pag-inject ng insulin, yung immune system magre-react, magpo-produce ng antibodies, IgE antibodies, yan talaga yung antibodies natin for allergy. IgE antibodies against the insulin. Okay? And then because of the presence of this IgE antibodies, syempre yung mast cells, 'di ba sabi natin, na-discuss ko na ito, mast cells plus contains the histamine inside. Ito yung mga granules niya. Pag nasira yung mast cells na yan, mapoproduce yung histamine and then mag-cause na siya ng allergy. Okay? And then meron ding immune insulin resistance na tinatawag. Okay? Kahit pa kahit pa hindi ito antibiotic, may resistance pa rin tayo dito. So ito yon, a low titer of circulating IgG anti-insulin antibodies that neutralize the action of insulin to a negligible extent develops in most insulin-treated patients. So hindi lang IgE ang ma-form, kaya ang IgE is more on the allergy. Pag ang na-form is the IgG, ma-neutralize niya ang insulin mismo. And pag na-neutralize niya ang action ng insulin, wala na siyang effect. Therefore, resistance na ang sunod. Okay? And then we have lipodystrophy at injection sites. Okay, again, lipodystrophy at injection sites. Pag sinabing lipodystrophy, ito yung namamatay ang fat tissues doon sa subcutaneous part wherein we inject the insulin. So, to avoid lipodystrophy or atrophy, kailangan palipat-lipat ng injection site. Kung nag-inject ngayon sa tiyan, hanap ka ng ibang part. Wait lang, class. Hanap ka ng ibang part for the injection na may nag-inject. Si Dean. Wait lang.